the reasons, or one of the many reasons, that we don't have a standard algorithm for managing first relapse of myeloma on lenalidomide maintenance, or really in any scenario, is because of the disease heterogeneity. There's at least 7, 8, maybe 12 different molecular subtypes, and they may have different natural histories and sensitivities to different drugs. And as the disease progresses, and at different sites in the same patient, there may be different biologic features of the myeloma clone. So to expect a one-size-fits-all approach for all patients is really not reasonable. And this is different from some diseases. I use the example often of diffuse large B-cell lymphoma, when there's a broad consensus on the best first-line treatment, second-line treatment. And the other confounding factor is we have a number of effective drugs, which is wonderful, but then it begs the question of how do we use them wisely? And then there are patient factors. Patients may not be able to come into the clinic frequently and get parenteral chemotherapy. They're infirm, they may not have transportation, they have mobility issues due to skeletal damage from myeloma, they have other medical comorbidities. So we struggle with wanting one instruction sheet of information, and it's not going to happen in myeloma. And of course, that makes it very confusing, because in terms of everything from funding to patient education to physicians' ability to make the optimal choice, there's just uncertainty and confusion. But the bottom line is there are many, many drugs we can use, and we really have to look at each patient separately, what they've had before, what we have funding for, and now we have to be careful to use the best regimen, but try not to close doors to other treatments. For instance, in Ontario, we're only funded for one triplet regimen for relapse. So if we use one, we can't use another one that may be effective, because these regimens, by and large, are quite expensive.